Now, as we have discussed in the previous lecture, that adaptation is the first step against any injurious agent. Um, it's a response to any cell. As we have all know that adaptation, cell injury, reversible or irreversible injuries depends upon the type of the injurious agent, frequency of the or intensity of the injurious agent, and the prolongation or the time duration of any injurious agent. Apart from this, there is another factor which can also help in response of against any other stimuli, is the type of the cell on which injurious agent is acting. It means whether this cell is very fragile, it will directly go into that cell injury step. Or if it is robust, then first it will try to adapt itself and then it will go into the cell injury if the injurious agent persists. Now, adaptations are reversible changes in the size, in the number, in the phenotype, how a cell will look like, its metabolic activity, or functions of the cell in response to changes in their environment. Such adaptations may take several distinct forms. So there are many forms of adaptation, but these are the few changes that you should know or you should look for. Whether the size of the cell is changed, whether the number of the cell is changed, whether the phenotype, the total differentiation of the cell is changed, whether its metabolic activity is changed or the function of the cells is changed. Now these are the four main adaptation forms. Number one is hypertrophy, second one is hyperplasia, then atrophy, and then metaplasia. Now the first entity, which is hypertrophy. The definition of hypertrophy, it is refer to an increase in the size of the cell, it resulting in an increase in the size of the organ. So hypertrophied organ has no new cells formation, just larger cells. Now this is the best example of hypertrophy, the cardiac myocytes, in which there is a very less or total absence of proliferation power or division power. Now you can see there is a normal myocyte above. When there is a cell injury, there is a reversible injured myocyte, which leads to irreversible cell death, and then infarction or necrosis occurs. However, there is another way of adaptation when there is a injurious agent is less, or there is a not that much severe, to give directly the reversible injury. First, the myocyte adapts itself, and then it goes towards hypertrophy. Now you can see on the left side of the diagram, there is an adaptation or the response to increased load. Whenever there is an increased load of any tissue, it will turn up into enlargement of the cells. You can see this kind of thing in skeletal muscle. Whenever there is an exercise or the over exercise, you can see in athletes, there is an hypertrophy of the muscles. Now, in myocardium, there is an increased load because of the increased hypertension or because of the increased blood pressure. Then this increased load will lead into adaptation of hypertrophied myocytes. You can see in the left side, and you can see the differentiation between them. That there is on the right side there is a infarction or total death of the cell, while on the left side there is a hypertrophy which approximately totally obliterate the ventricle lumen. Now the types of hypertrophy. It can be physiological, it can be pathological. The most common stimulus for hypertrophy is increased workload or hormonal induced hypertrophy. So these are the main two reasons or the cause of hypertrophy. It could be physiological, it could be pathological. Now in the previous slide, as you know, that the major cause of hypertrophy is increased workload and the hormonal induced work hypertrophy. Now these are the few examples. Number one, cardiac and skeletal muscle enlargement or hypertrophy due to increased workload. In cardiac muscles, you can see during increased blood pressure, or in skeletal muscle, you can see physiological kind of hypertrophy due to exercise, right? Then there is another example of hypertrophy, which is smooth muscle cells hypertrophy, and it is due to hormone induced during the pregnancy, which is present in uterus, right? Now one thing that you should know, for best examples and not so best examples of hypertrophy. Why? Because if you are seeing any hypertrophy in an organ which cannot divide, the cells cannot divide or incapable of mitosis, then you can say that this is the best example of hypertrophy. Like in neurons, cardiac myocytes and skeletal muscle cells. They were considered to be incapable of mitosis, and throughout their lifespan it remains originally differentiated in differentiated state. Differentiated state means it is not dividing as well as it remains into that cell. It is not going to proliferate. Yes. And then in other organs like kidney, thyroid cells numbers and cell size may both increase. So hypertrophy and hyperplasia you can see simultaneously in these kind of organs. So this is not the best example of hypertrophy. So in other organs like kidney, thyroid cell numbers and cell size can be increased due to the because they are capable of mitosis. So you can see hypertrophy and hyperplasia both in these organs, but not in cardiac myocytes. Hyperplasia won't see any hyperplasia in neurons, in cardiac myocytes or skeletal muscles. Right? You get the point? Now there is another example of hypertrophy at cellular level, in which those patients who are treated with the drug barbiturates or alcohol, those who are alcohol abusers, their cells sometimes show hypertrophy of smooth endoplasmic reticulum in hepatocytes, which is an adaptive response against this injurious agent, barbiturates and alcohol. So basically the function of the smooth endoplasmic reticulum is to secrete an enzyme P450 which acts as a detoxifier, and this due to the increased availability of injurious agents like barbiturates and alcohol. So smooth muscle cells, smooth endoplasmic reticulum will have to work hard, or will have to work, overload will be increased. So due to the increase in the work overload, because it has to secrete P450 enzymes much more than its normal capacity, it has to work hard. So you will see enlarged smooth endoplasmic reticulum in hepatocytes. Now this is an example of physiologic hypertrophy of uterus during pregnancy. In diagram A, you can see the gross picture. In diagram B and C, you can see the normal and the gravid uterus smooth muscle. In diagram A, you can see a normal appearance of normal uterus on the right side and a gravid uterus removed from a postpartum bleeding is on the left side. So we can differentiate how bigger uterus becomes. Yes. Then in diagram B, you can see a small spindle-shaped uterine smooth muscles from a normal uterus compared with the C large lumpy cells from the gravid uterus at the same magnification. So you can differentiate microscopically and fluorescently. Now this is a pathological hypertrophy example in which you can see there is an increase in the blood pressure leads to adaptive response of cardiac myocyte, that is hypertrophy. You can see in the transverse section of ventricles. In the above one, this is the normal ventricle or heart, in which you can see the lumen inside the ventricular wall. But there is a total obliteration of the lumen in the lower slide or the lower one because of the increase in the hypertrophy, increase in the size of the cell of the myocyte. Now hypertrophy can be induced by the actions of mechanical sensors, growth factor stimulations, neuroendocrine stimulations, ion channels, chemical mediators, or oxygen supply. So these are the factors that could lead hypertrophy. Now the process of hypertrophy is basically based on three basic steps: molecular pathogenesis of cardiac hypertrophy. We are taking it as an example. Then number one is, first of all, what happened, the integrated action of mechanical sensors that are triggered by increased workload, or apart from mechanical sensors, growth factors and vasoactive enzymes triggered. Then it sends signals which are present in cell membrane. Then these signals originating in the cell membrane activate a complex web of signal transduction pathways in the cytoplasm, and these signaling these signaling pathways activate a set of transcription factor, and this transcription factor works coordinately to increase the synthesis of muscle protein, and which in response leads to hypertrophy. So basically it's an activation of the sensors or growth factors and vasoactive enzymes, and then it sends signals inside the cytoplasm which transcript through the signal transduction. It transcript to the nucleus, and this transcription will send formation of further protein production. So the basic reason for hypertrophy is the result of increased production of cellular protein, and these stimuli work coordinating to increase the synthesis of muscle proteins that are responsible for the hypertrophy. There is also another way of hypertrophy. In some stress, there is a change of contractile protein from adult to fetal or neonatal form. In this condition, in this process, some genes that are expressed only during early development are re-expressed in hypertrophic cells, and the product of these genes participate in the cellular response to stress. So this is how the a cell will respond to survive uh, with the injurious agent, right? And at some time, at after some time, the contractility of the cardiac muscle will be limited, and it goes into that condition of cell death or irreversible injury. So this is the first adaptation hypertrophy occur, and if we are not going to uh, remove the injurious agent, then it gives you irreversible injury, which is cardiac failure. Now this is the schematic diagram of mechanism of hypertrophy. You can see a cell with sensors, hormonal sensors, mechanical sensors, and there is a increased workload in the mechanical sensor, and there is an increase in the growth factor at the growth factor sensor. Then there is a increase in the sensor activity, leads to signal transduction in the pathway, proliferates and forms the contractile protein. Now you can see there is an increase in the production of protein, which leads to increased size of the cell. Now the second entity of adaptation is hyperplasia. Hyperplasia is an increase in the number of the cells in an organ or tissue. Of course, it is resulting due to it will result in increased mass of the organ or tissues. Hyperplasia takes place if the cell population is capable of dividing and thus increasing the number of cells. So as we have discussed that hyperplasia you can see in different organs where hypertrophy of course can happen, but the main thing that is needed is that hyperplasia can only occur in those tissues which are capable of dividing, like smooth muscle cells, hepatocytes, renal cells. Now this is the example of hyperplasia. You can see skin. On the left side there is a normal epidermis with the underlying dermis, and on the right side there is an epidermal hyperplasia, and the condition or the disease you can see is psoriasis, where you can find the dermis is going deep inside the dermis, epidermis is going deep inside the dermis, and it is hyperplastic as compared to the normal one. Now there are two types of hyperplasia. One is physiological and the other one is pathological. Physiological hyperplasia can be due to hormonal effect or it can be due to compensatory hyperplasia. In hormonal hyperplasia, we have an example of proliferation of glandular epithelium of the female breast at puberty and during pregnancy. While in compensatory hyperplasia, there is a capacity of liver to regenerate after hepatectomy. And or maybe you can see in one kidney when there is the other kidney is removed. So this is physiological hyperplasia. Now in pathological hyperplasia, we have an example of benign prostatic hyperplasia, endometrial hyperplasia, and skin warts. So the causes of benign prostatic hyperplasia is due to over excessive testosterone stimulation, while for endometrial hyperplasia there is estrogenic stimulation continuous, or maybe abnormal estrogen secretion due to any reasons, could be cancer. And in skin warts there is a proliferation or hyperplasia of the epidermis due to any viruses like HPV or HSV, right? So these are the few examples of hyperplasia. Now the mechanism of hyperplasia, it is results due to growth factor, which leads to proliferation of mature cells, and in some cases by increased output of new cells from tissue stem cells. After partial hepatectomy, growth factors are produced in the liver that engage receptors on the surviving cells and activate signaling pathways that stimulate cell proliferation. In the hypertrophy, we have learned about the protein production, which increases the size of the cell, while in hyperplasia there is an increase in the division of the cell. The signaling will give signals to mitosis to proliferate, right? So this is mechanism of hyperplasia. Now this diagram shows normal adult bone marrow on the left side, and in diagram B you can see the hyperplasia of the bone marrow, which shows the increase in the cellularity and decrease in the fat component. So on the left side, this is the normal one where you can find a few cells, bone marrow cells, which proliferate, but mostly it is occupying, fat is mostly occupying the bone marrow. It is a normal adult bone marrow. While you can see on the right side there is a increased cellularity due to the overproduction of cellular component, and it is maybe due to any reason, but this could be pathological or it could be physiological, but this is how it looks like, bone marrow shows. Now the third form of adaptation is atrophy, in which you will find there is a reduced size of an organ or tissue, which is resulting from a decrease in the cell size and number. Atrophy of an organ is basically occurs due to the reduced demand for cell activity. Basically, there are three ways in which a tissue can respond to a reduction in functional demand. Number one, it could be due to get rid of cytoplasm or structural proteins that leads to cell shrinkage, or maybe it will eliminate whole cells, or maybe it both mixture of the tools, above tools. Means it could get rid of cytoplasm and it could eliminate whole cells. If the cells are lost in an organ, they are often replaced by collagen or fat. Collagen is dense and featureless, sometimes called hyaline, hence the term hyalinization of the tissue occur, and this implies loss of functional specialized tissue and replacement of connective tissue. And so, in return, we have a reduced size and mass of an organ. Now the other causes of a small organ or other than atrophy is hypoplasia and agenesis. Atrophy you can find whenever there is a disuse of this particular organ that could lead into atrophy. But if you see some small organ, it doesn't mean that it always gives you an entity or you label it as an atrophy. But there are some other reasons of small organs. One is hypoplasia, in which you will find incomplete growth of an organ, or agenesis, that is complete failure of development of an organ in embryogenesis. Now the examples of physiological atrophy, which is also termed as involution, it is due to mainly withdrawal of results because of the result of withdrawal of an endocrine stimulus. Examples of involution is breast after cessation of lactation, uterus after parturition, thyroid after puberty. So these are the physiological atrophy in which there is a withdrawal or cessation of endocrine stimulation, leads to involution of the organ. Now this picture is showing normal brain of a young adult in picture A, and in diagram B you can see the atrophy of the brain in an 82-year-old male. Now you can differentiate the two brains and by seeing gyri and sulci. In normal brain of a young adult, you can see normal measures of sulci and gyri size, while in the diagram B, in atrophy of the brain in 82-year-old male, there is a increase in the sulci, widened sulci, right? The meninges have been stripped from the right half of each specimen to reveal the surface of the brain. So this blue coloration membrane is the meninges on the left side of each of the hemisphere, and it is removed from the right side. Now the pathological atrophy can be localized or generalized, and the cause of this pathological atrophy could be due to decreased workload, that is atrophy of disuse, due to loss of innervation, that is denervation of the organ, or a diminished blood supply, inadequate nutrition, or loss of endocrine stimulation, or due to any surrounding pressure. So these are the cause of the pathological atrophy. Now this is pathological atrophy diagram. Microscopically you are seeing normal muscle, skeletal muscle, and in the above picture you can see the normal muscles, and in the lower picture you can see the denervated muscles. Denervation is occurring and then it leads to atrophy of the muscle. Now this is another picture, microscopic picture of atrophy, in which there is an example of endometrium on the left side. This is the normal atrophy, normal endometrium, while on the right side you can see the atrophied endometrium. You can see the widened area of endometrium which is covering on the left side, while there is a hardly one or two glands you can see on the right side of the endometrium. So this is the lining of the uterus. You can see a section in section A. This is the normal uterus from a woman of reproductive age, reveals a thick endometrium composed of proliferative glands in an abundant stroma, while in diagram B or picture B you can see the endometrium of a 75-year-old age, and it is thin and contain a few atrophic cystic glands, but both are at the same magnification. Both pictures are at the same magnification, right? Now for the mechanism of atrophy, you can see atrophy results from decreased protein synthesis and increased protein degradation in cells. Basically this is the basic mechanism of atrophy, in which there is a decreased protein synthesis and increased protein degradation. Protein synthesis decreases because of the reduced metabolic activity, or there is no need for protein synthesis. That's why atrophy occurs. Now this is a quick review or a quick overview how a protein is degraded and released from the cells, damaged protein, so cell can live. The cells contain abundant free ubiquitin, What is ubiquitin? Basically, it's a protein which activated by a series of proteins and can then be covalently bound to the damaged protein. Means ubiquitin is the protein which takes the degraded protein from the cells, which is no more needed for the cells. The proteins which are no more needed for cells will be taken up by the ubiquitin, and it presented to uh, a proteasome, multi-catalytic proteasomes. These multi-catalytic proteasomes are the enzymes which are present in the cytosol, and these sols basically these enzymes basically take the ubiquitinated protein, and basically it recognizes ubiquitin recognize these degraded protein to this proteasome. So when once proteasomes recognize the damaged protein, it releases ubiquitin for recycling and then degrade and eliminate the damaged protein. So cells with an impaired ubiquitin system do not survive. Those cells who are impaired of ubiquitin system, but those who doesn't have this protein ubiquitin will be won't able to survive for cell stress and usually die quickly. Now this is a ubiquitin system diagram, a very beautiful diagram in which you can see the blue oval shaped free ubiquitin. The cell contains abundant free ubiquitin, and this free ubiquitin is activated by a series of proteins and can then be covalently bound to damaged protein, which are present in the yellow coloration. These are the damaged proteins by ubiquitin ligases, and that damaged proteins conjugated to ubiquitin is termed as ubiquitinated protein, right? And then it is presented to proteasome, which is degraded. Then this proteasome release the free ubiquitin for recycling, and the degraded protein releases from the cell. Now this is the overview. What are the different events in cell atrophy? Cell components are removed by degraded system, cytosolic proteolysis by ubiquitin system, then autophagy, that is elements enwrapped by internal membrane systems and fused with the lysosomal system. So it gives the nutrition for the cells. Autophagy we have learned in the previous lecture. What was autophagy? Autophagy was when the cell needs nutrients and it eats itself. This is called autophagy. Then residual lipid materials may remain in cells as a brown material termed lipofusin. Lipofusin pigments are the wear and tear pigments which are present in old age cells. Now autophagy is the process in which the starved cell eats its own component in an attempt to find nutrients and survival. Autophagy vacuoles are the membrane-bound vacuoles that contain fragments of cell component. The vacuoles ultimately fuse with lysosomes, and their contents are digested by lysosomal enzymes to get energy. Right? Then residual bodies present in the cytoplasm. Now this is the schematic diagram of autophagy, in which you can see cytoplasmic organelles which are forming vacuoles by the membrane, cellular membrane, and it present inside the cytoplasm due to the nutrient deprivation or nutrient depletion. autophagy signal starts, and then it forms autophagic vacuoles, which attaches with the lysosome, which is the digestive system of a cell, and this lysosomal attachment will give the nutrients or energy to the cell, and then the degraded material secrete out from the lysosome and present inside the cytoplasm. Now the fourth entity of adaptation is metaplasia. Metaplasia is a reversible change in which one differentiated cell type, that could be epithelial or it could be mesenchymal, is replaced by another cell type. So this metaplasia basically is the total phenotyping change. A cell will look like another cell. Maybe squamous cells could be changed into columnar cells, right? Now the examples of metaplasia is, most common one is the epithelial metaplasia, in which the columnar is changed into squamous cell epithelium. For example, in case of cigarette smoker, the normal ciliated columnar epithelial cells of the trachea and bronchi are often replaced by stratified squamous epithelial cells due to the chronic irritation. And in excretory ducts like salivary glands, pancreatic or bile ducts, if there is a impaction or the occlusion by the stones in the ducts, it leads into the replacement of normal secretory epithelium lining by the stratified squamous epithelium. So in both of the cases, cigarette smoker and in the stone infection, there is a chronic irritation, or chronic irritation leads to change of one cell into another one, columnar epithelium change into squamous one. Here you should remember that there is not a complete mature adult cell change into another one. Means that one adult cell, if you are looking at the one adult cell, it won't dramatically change into another one, but the next one, or the stem cells which are going to make columnar cells, are further signaling towards not forming columnar cells but to form squamous epithelium. So this is the change of the epithelial, and once the stem cell of columnar cell changes into squamous epithelium, then it gives adult epithelium like a squamous epithelium, right? Now the example, another example of metaplasia, epithelial metaplasia, is due to deficiency of vitamin A or retinoic acid, which induces squamous metaplasia in the respiratory epithelium. And there is a metaplasia from squamous to columnar type, which you can see in Barrett esophagus, in which the esophageal squamous epithelium is replaced by intestinal-like columnar cells under the influence of reflux of gastric acid. So this is an example of metaplasia, epithelial metaplasia from squamous to columnar epithelium. Now this is the schematic diagram and the microscopic picture of metaplasia of columnar epithelium. You can see in the schematic diagram there is a normal columnar epithelium changes into squamous metaplasia on the right side. You can see the basement membrane, normal columnar epithelium, and squamous metaplasia. And in the below, in the diagram B, you can see the microscopic picture of squamous, that is columnar epithelium on the left side is changed into right-sided squamous epithelium in the bronchus. Now this is also another example, squamous metaplasia. You can see the pink coloration, which is showing the transitional epithelium of bladder, is changing into the arrow which is showing in the green color, the squamous epithelium, and this is the total transitional epithelium is changed into squamous epithelium. Now the connective tissue metaplasia or mesenchymal tissue metaplasia. You can see cartilage, bone or adipose tissue abnormally present in those tissues which are not normally contained. These cells are termed as or you can label it as a connective tissue metaplasia. But they all will show you the mature cells, not the blastic ones. Blast cells always gives you a clue of malignancy. Whenever you see a differentiated or well differentiated cells which are abnormally present, then you can call it metaplasia. Like a bone formation you can see in muscles, sometimes due to the chronic irritation or due to intramuscular hemorrhage. This designation is called as a myositis ossificans. Due to the internal muscular hemorrhage, after some time or after a long period of accumulation of these hemorrhage leads to bone formation here. So this is another metaplasia, connective tissue metaplasia. As before we have discussed that metaplastic change or adaptation is reversible. The influences that predisposes to metaplasia or the causes that predisposes to metaplasia is persistent, then it may initiate malignant transformation in metaplastic epithelium. A common form of cancer in the respiratory tract is composed of squamous cells which arises in areas of metaplasia of the normal columnar epithelium into squamous epithelium. So it can give squamous cell carcinoma. Now these are the cellular adaptations to disease: original tissue, stimulus and metaplastic tissue. Original tissue in bronchial tree is ciliated columnar epithelium. Due to chronic irritation of cigarette smoking, it turns into squamous epithelium. Then transitional epithelium of bladder, due to calculus or continuous irritation of stones in bladder, turns transitional epithelium into squamous epithelium. Likewise, columnar epithelium in the gland ducts due to calculus or stone trauma or chronic irritation turns squamous epithelium. And fibrocollagenous tissue, as it is mesenchymal tissue, due to chronic trauma turns into bone tissue or osseous tissue. Then esophageal squamous epithelium due to gastric acid turns stratified squamous epithelium of the lower esophagus into columnar epithelium. Then columnar glandular epithelium, glands contain columnar epithelium normally. When there is a vitamin A deficiency, then it turns into, or metaplastic change occurs into squamous epithelium. Now the mechanism of metaplasia is when metaplasia does not result from a change in the phenotype of an already differentiated cell type, as we have discussed. Instead, it is a result of reprogramming of the stem cells that are known to exist in normal tissues or of undifferentiated mesenchymal cells present in connective tissue. So, as we have discussed, it is not a total change of the already differentiated cell, but a stem cell will be reprogrammed to produce another kind of stem cell, another kind of mature cell. This is the mechanism of metaplasia. So thank you so much for your patience. I hope